You know, this is emergencies. This doesn't always necessarily mean it has to be done in the middle of the night, but an awful lot of these cases do have to be done in the middle of the night. We can lower the lights whenever, oh, well, they're taking pictures. So, what's my good side? There are no good sides. So what are the usually things? You know, they come into broad categories. Interventional radiologists are very simple people. We don't know anything about restricted diffusion. We don't know anything about half the things that Dr. Schweitzer or Dr. Chatterjee talked about. We think about big things. We've got bleeding, we've got lack of bleeding or ischemia, we have sepsis, and we have obstruction, and then we have an other category. So hemorrhage. Hemorrhage is one of the things that certainly is considered an emergency in many cases, and that can be from trauma due to organ injuries, vascular injuries, gastrointestinal bleeding, or other, well, we're going to get into other between hemoptysis or tumors. So I'm going to start by just showing a little bit about what can we embolize with. So hemorrhage is very simple. Usually you block up that blood vessel. Not always. It could be that we put a stent or something to cover the hole. But the point is, if there's a hole in the vessel, you've got to block it. So permanent agents, absolute ethanol, polyvinyl alcohol, or people would say PVA particles. There are a variety of spherical embolic materials now. Classic one is embospheres. We have liquids, glues, and a variety of polymers. There's a whole bunch of new category of embolic agents that are just being released now that are coming on the market. And Amplatz plugs, coils, detachable balloons, and temporary agents such as autologous blood clot and gel foam. So, these are the tools of our trade, our catheters. Here's 1 millimeter, and you can see the catheters, different sizes, and then you'll see a catheter with another catheter through it with a guide wire. And compared to the 1 millimeter, these catheters can be extremely small, and the guide wires can be down to 10,000ths of an inch in diameter for some of the complex neuro work. So things get smaller and smaller. So when things are getting smaller like that, how do you see these anymore? The smaller they get, they don't block X-rays. What do you do to them to make them show up? Put something on it that is really radio dense, and the most common things are gold and platinum. So, when you see a black thing on a guide wire, it's gold or platinum. And then the catheters themselves, the black is bismuth or barium, so you can see the ends of the catheter. So the embolization materials, here's some liquids, denatured alcohol, polyvinyl alcohol particles that come in different sizes, embospheres, they come in different sizes also, gel foam, which is a sheet that you cut up into little cubes, and embolization coils. Underneath that, there's a steel coil that has all these little Dacron hairs in there to promote blood clot. There are coils, there's what the coil looks like. There are coils that don't have fibers. A lot of those are used for the neuro work, for doing aneurysms, because you don't want these fibers sort of tailing off into the MCA and inducing blood clot formation. So Amplatz plugs, they're a nitinol. Did anyone go over nitinol? What it is? Nickel titanium. It's a shape memory alloy that you make it into a shape, you bake it in an oven, and it will remember that shape. So you can put this through a very small catheter. As soon as it comes out and hits the bloodstream, it goes right back into that shape. So, what's happening here? Bleeding. Okay. That sounds like an interventional radiology. What's happening? It's just bleeding. So, person had a multi-vehicle accident, and there is all this, lack of perfusion in the liver, and there is a bleeding in the liver. It looks like it's contained at this point, so it's probably a pseudoaneurysm, but you do have to treat these. And sometimes they're hard to find until you really get out there. because you've got to think that the CAT scan, the contrast has been floating around the system potentially for minutes, and then it will show up in the aneurysm. The exchange of blood in a pseudoaneurysm can be very slow. So it's not like a blood vessel that's going to flow quickly, fill the aneurysm, keep going. It may be that it's right at the end of the blood vessel, and it takes time for that contrast to get there. So on an arteriogram, you might not even see it. It just goes right by, and you've stopped looking, and the amount of contrast you give does not opacify it. So you can see this and say, oh, that doesn't look too bad, but very late, you see a little thing like this filling in. It really looked a lot clearer here, didn't it? Sometimes here, it doesn't. Sometimes you don't even see it until you are very, very selective. You know it's got to be there. So you can get more selective and do it. And you can also get issues. There's some thrombus in the vessel up here. You can see the filling defect. And eventually, what you'll do is you can, this is a zoomed up image. It's right here. So this vessel is this vessel. The whole right hepatic is gone now. What's going on here? What? Spasm. Yeah, notice it looks pretty normal there. Here it looks horrible. And that's exactly what that is. It's arterial spasm. So here's another one. So now we've got a splenic hematoma. So we've got pseudoaneurysm, but notice, look at, there's some lack, there's a little ring around the spleen, more blood. So there it is. So there's the aneurysm, and you can get way out there. There's the aneurysm, and you can coil that, and it goes away. So there it is after embolization. There's the coil, no more aneurysm. There it is after the fact. So, we're not going to go through the grading scale for splenic trauma, but, for very minor trauma, especially without a pseudoaneurysm, you can just it can do conservative management. But if you start seeing pseudoaneurysms and things like that, it's worth doing interventional therapy. Here's one that I did years ago. We had a transit strike in New York City. So there were no buses, there were no subways, everything had stopped, except for some private buses. Some private companies had buses. And that day, there was a gentleman that was riding to work on his bicycle. He was a firefighter in New York City. He was one of the training firefighters. And he was hit by a bus. Well, he was lucky. He happened to be right across the street from the hospital. And the EMS people were getting their donuts in the morning. And they saw this happen, so they scooped him up and brought him to the hospital. And it happened to be before the day started, so that there weren't already patients on the angiography table. And he went straight to the OR, had external fixation of his pelvis, and then this was his arteriogram. You can see he's already had a little quick laparotomy, and it was just full of blood. And the vessels look weird. Vessels shouldn't be small, large, larger, small again. These is just diffusely small. And here's the internal iliac, and it's missing on the right side. And look at this one. These vessels kind of look small, right? Well, why do they look small? They look small because he's lost so much blood that all the vessels are vasoconstricted to try to maintain blood pressure. So this is the hypogastric artery on the right. And you can see he has complete transection of his superior gluteal artery. So he got embolized. And later that same day, he had more bleeding. So we found more bleeding. And there's the coils from earlier in the day. So he came back, and he actually survived. He got 63 units of blood. 25 of them were in the interventional radiology suite. And this is him. So he ended up giving making an advertisement for the New York Blood Bank, saying, you may get it back someday. I did, and his name's Matthew Long, and he's a very, very nice guy. And the thing about him is he only had injury from here down. He was sandwiched between a bus and the bumper of another car. So everything that was here is fine. It was all just an absolutely crushed pelvis. So pelvic hemorrhage. Most bleeding in the pelvis from trauma is venous from the fractured bones. When it is arterial, then we can go in and embolize it. The retroperitoneum can hold a tremendous amount of blood, up to 4 liters or so, before there's so much bleeding that it stops the bleeding because there's now so much pressure in the retroperitoneum. How much blood is in your body? Is how much? Right, so 4 of them go into your pelvis. Are you going to be doing very well? No. So that's the thing. You can bleed, usually people will die before tamponades. But the point here is most of it is venous. And it's actually relatively rare to have large vessel injuries like transections of the iliac artery. Again, usually those people don't do very well. They never make it to the hospital. Here's another one. This is interesting. This is a tumor. There's a tumor, and then you can see, well, there's some bleeding into something around, where's the artery? But there's a tumor in here with the bleeding into it. And here's the arteriogram with extravasation and a fistula to the sigmoid colon. So this is filling up the bowel. And this one, you could, embolize it, okay, but if you embolize it now, what are they gonna do for their leg? So this one was treated with a covered stent graft. The hematoma was drained and a stent graft was placed, and this is the vessel afterwards. So a male with recurrent pancreatitis. So you can see all the pancreatitis, right? Old, burnt out. What's the abnormality other than the pancreatitis? Speak up. What? Yeah, there's a pseudoaneurysm. It's enormous. That's all a pseudoaneurysm. You know right where that has to be. That has to be in the head of the pancreas, right? Where is it? Here's the celiac, hepatic, gastroduodenal. You don't see it. And I know I'm only showing one picture. You don't see it. Here's the splenic, the SMA injection. No, it's not filling from there. Here's another one. Don't really see it. Here's more selective. Still don't really see it, except there's some little thin vessel here. And if you're thinking about it, that vessel isn't, it almost looks like it's curved around something. Well, when you get far enough out, there it is. So sometimes, as I was saying, you can see something that is absolutely blatantly obvious on the CT because it had time for the contrast to get in there. And on angiography, you might not see it till you're right there, and then this was easily treated with some coils. And then I wish I had done the ultrasound before I did it, because now afterwards you could actually image it with ultrasound, and you can see this hematocrit level where it is now not flowing anymore and all the blood is settled to the back. This was a case, this is a really old case because this was during my fellowship. Why are you smiling so hard back there, Schweitzer? Okay. Andrew knows there's a hospital that we go to now routinely called LMH, or Lower Manhattan Hospital. Back in the day, it was called the Beekman Downtown Hospital, and it was an independent hospital. This is a case from there. So one night, I get a call, and as a young woman presented to the ER at the Lower Manhattan Hospital, or now, and was pregnant, fetal distress. They did a C-section, delivered the baby, and they noticed an expanding retroperitoneal mass. So what did they do? They closed the patient up and they sent them up to Cornell. So what do you think it might be? It's a hematoma, but from what?
Bleeding AML.
A bleeding AML. I told you were going to see another one. Okay, so we didn't even get the CAT scan. We did the angio, and you can see this is a recent postpartum. This is actually an ovarian artery coming down, very tortuous. This is very typical of the look of a postpartum. But you can see all the bowel is over here. There's no bowel on the right side. And this is the kidney, and like, look at these aneurysms. You do a closer one, and there's the kidney smushed. There's all these vessels, aneurysms, and a little heart. This is the classic look of an AML. And so we went in and embolized until we had this. And then we got the CT scan. So there's the CT scan, there's the kidney, there's this big fat containing mass with blood. And she actually did really well. She ultimately, about 4 months later, after most of the blood, they went in and resected the AML. She didn't lose her kidney, and the baby did fine. But as a fellow, back in the day when I was a fellow, there were no attending physicians at night. So this was like, oh God, well now what do I do? But gastrointestinal hemorrhage, most of it is endoscopically treated. Interventional treatment. We used to do vasopressin infusion to spasm the vessels. We don't do that anymore. It's embolization. So here's a good one. There's a nice bleed right into the small bowel. So from the gastroduodenal, no question that they were bleeding. So sometimes it's hard because GI bleeding is intermittent. So you may see it, you may not see it, it may stop and start. It's actually really nice when you see this, go, I know right where that is. So then you can embolize it. This was another case, 50-year-old with lymphoma, large amount of blood per rectum. And here's the arteriogram. Even from the aortogram, where's the bleeding? Right there? So it's a very distal branch to the colon. There is a small catheter out to the colon. And the first coil I put in actually went inside the bowel. It went through the hole. So here's the other coil. And no more bleeding. Massive upper GI bleeding, endoscopy showed diffuse gastritis. What do you usually do for those patients? You do a left gastric embolization. Usually you don't see anything. Very rarely do you see the bleeding in the stomach. But in this case, just with a celiac injection, there is another little pseudoaneurysm. There it is. And after embolization, it's gone. So I said, usually you don't see it and you do an embolization anyway because a left gastric artery embolization is so well tolerated by patients. If there's any question, you just embolize it and don't worry about it. There's now this whole thing of embolizing the left gastric artery for appetite control that some of the hormones created in the stomach. If you embolize the source of those hormones, it'll make people not eat so much. All right, here's an MRI. Okay, how about this one? So this is a trauma. There's something weird here. So there's some there's something, you may not see extravasation into the thing, but there's blood in there already. So this is the more typical thing you'd see with angiography, is that you'd see this abnormal widening of the aorta at that level. So where do people bleed in trauma? The what? Okay, infundibulum, is that the most common? Ligamentum arteriosum, it's where the aorta is tethered. Exactly, tethered, not fixed. So where does that occur? Aortic root? Ligamentum arteriosum, as you were saying here, and the diaphragmatic hiatus. So it's usually here, here, or here. The problem is you almost never see the aortic root tears because the patients don't make it to the hospital. Those are the ones that end up with dissection, tamponade, coronary arteries that have been dissected off. They don't survive to get to the hospital. So the most common one you see is aortic isthmus. And now a lot of these are treated with stent grafts that you can go in and put the stent graft through here and seal it all back down. And then here's what that looked like 4 months later. It looked very normal again. So 1 week postpartum with a severe hemorrhage. What do you think that might be? Postpartum after delivering a baby? Yeah, pick a different artery. Well, we're back to, well, why would you bleed? Well, you select, so we will select the vessels going to the uterus. There's one here, there's one here. This one looks pretty normal. That's a very normal postpartum, recently postpartum with tortuous uterine artery filling the uterus. But you look at the other side, we've got our pseudoaneurysm again. So we embolize that with gel foam, which is like a sponge. It's a gelatin sponge that will slowly dissolve so that the vessels hopefully will reopen. And then after the gel foam, it stopped. Okay, we're going to move from bleeding to ischemia. Okay, this is a person with severe abdominal pain, out of proportion to physical exam. Just from that history, what do you think I'm going to show? Right, so mesenteric ischemia, and that's the classic thing, that the gut is ischemic and people have severe pain even though you can push on them and it doesn't really hurt that much, but they have pain, particularly after eating. In this case, this person, you can see how ugly this aorta is, and you don't really see, you see a kidney. Where's the celiac? Where's the mesenteric vessels? Here's some out to the liver. Again, where are the vessels going to the bowel? And this is the catheterization. That's the SMA, this very ugly, irregular thing. What? Oh, from some prior surgery, I don't know what. Probably a nephrectomy, because there's only one kidney, I don't know. So this is the SMA, and believe it or not, this is after stenting, and the patient's where symptoms are improved. This was a really weird case to have. 7-year-old male with a 5-day history of worsening right foot pain, which progressed to loss of sensation in his toes. So obviously he's got something ischemic going on with his leg, but he's only 7. What could cause ischemia in a 7-year-old? Could he have atherosclerotic disease? Maybe. Could he have an AVM that's stealing from that leg? Possibly, but usually that's not going to progress very quickly to loss of sensation. So he came in and we did an arteriogram. Again, this is old enough before there was good CT or MR. And this was the bilateral femoral station. These are the knees right here. So what's happening in his right leg? So he's got, certainly there's something skipped, there's an embolus here. There's large collaterals already, and he's got some clot in that too. And does anything look odd about this? The diagnosis was made from this picture. That's an excellent thought. It's not a tumor. Exactly. So this is a chronic condition. And then it thrombosed. Look at the course of the vessel. There's only one reported case of it in a 7-year-old, and this is it. But that's exactly what this is. This was suspected to be popliteal entrapment. But the first thing you have to do is fix the legs. So these are the tibial vessels, and thrombolysis was done. The next day, it looked like this. With now we see the vessels. You still see that it's not perfect. But this is a 7-year-old, and he was in the ICU awake all night with catheters in him, and at this point his foot is red and hot and normal sensation. So we brought him back after thrombolysis, but first we did an MR. So here is the muscle inserting on the wrong side of the popliteal artery, and it's very commonly bilateral. You've got to look at the other side. Here's the same thing happening in the left leg. So after a month, we did an MR arteriogram, and now you can see the aneurysm. It's also interesting, you had continued thrombolysis. Now the vessels are completely open. So the treatment for this is surgical. So this is the operation where the vessel is isolated, the aneurysm is resected, and the vessel was primarily repaired. And after it was repaired, it was nice and straight. So kind of a neat case. But of course, when does that happen? 3 o'clock in the morning. Popliteal entrapment, it's a common cause of claudication in patients under 50, but it had never been described in a child before, so we at least got a paper out of it, even though it was 3 in the morning. So let's see, where are we now? We've got lots of time. 32-year-old male with possible graft versus host disease. So, we've got a person that had a liver transplant, so now we want to do a biopsy. So we go in and we take our biopsy specimen, and after the biopsy, we take the needle out, and we get this. Yeah, okay, there's some hematoma on the liver. So what do you do now? It's not much of a hematoma. Maybe it'll stop. So you wait. And then you do another scan. Oops. Now, at this point, the blood pressure is starting to get a little lower. Now they have to have an arteriogram. So there it is. You can see, again, diffusely narrow vessels because they're patients in hemorrhagic shock. And there is our bleeding. So you've got to get out there and block it up. And after it's blocked up, this is after it, the bleeding had been out here, patient did fine. So hemoptysis. We're getting through these pretty quickly. Cystic fibrosis with massive hemoptysis. When I went to India years ago, I asked, the interventional radiologist there, what brings you to the hospital at night during the week? And they said it's hemoptysis, but it's always due to TB. We don't see that. We almost, I've only seen one case of it in our hospital. We always see it from cystic fibrosis. So we get hemoptysis, and usually the patient can tell you which side is bleeding. They know. But we always want to know, so we usually have a bronchoscopy and tell us which side. Because in a cystic fibrosis patient, every bronchial artery is going to look abnormal. And you won't see the bleeding. You'll just see abnormal vasculature. So you say, it's bleeding from the right upper lobe, it's bleeding from the left upper lobe. We need to know so we can figure out which side, because this is what you'll typically see. You'll see a bronchial here, there's a bronchial here. You'll see some more sometimes going off to the other side. Occasionally, you'll even see it coming down. It'll feed off of the internal mammary artery. So you've got to go and you end up catheterizing the area that you know is bleeding and embolize that. Now, what do you really have to worry about doing a bronchial artery embolization? Spinal arteries, you said? Spinal ischemia is the worst complication you can have. And the reason being is that there are very frequently off the proximal bronchial artery or a bronchial intercostal artery, there may be a tiny little feeder that goes into the spine that feeds the anterior spinal artery. And if you embolize that, yes, she's over here, someone's going, not good. Not good, because, and the other thing is you also want to be very careful of what embolic agents you use. You do use particles, but you never want to use ethanol, glues, things like that. Liquid embolics have a tendency to get into these spinal arteries a lot easier. If you use larger particles, these are usually very small arteries, the spinal arteries. So if you end up with larger particles, they're too big really to get into the origin. They'll just go by. So what's the real one? There's one particular artery you want to avoid and look for. The artery of Adamkiewicz, yes. That's the one, and that is the one you really want to worry about. It's highly variable where it comes from. It's from T8 to L4, and usually on the left side. So, okay, you've done this, and now you've got a patient that's paraplegic. Well, other than you panic, what can you do to try to help preserve as much neural function as possible? You put in a spinal drain, and you decrease the spinal perfusion, and you want to also make sure that the patient has a relatively elevated. Might even want to elevate their blood pressure, and put in a spinal drain to keep the spinal cord pressure as low as possible, and that will help any blood that can get through any collaterals. Usually, they're going to stay paraplegic, but that does sometimes limit the problem. So this is back in the day when we used to do catheter-based pulmonary angiography. You can see the clot literally bouncing up here. In chest X-rays, what's one of the signs you get with Western mark? What is that? The post what? Paucity of vessels. This shows you what the Western mark sign is. So if you go and look, notice there's a paucity of vessels out here. So this is exactly what it is. It's a big clot sitting there preventing blood from getting out there. So now there's different categories of pulmonary embolism. When I was training, it was very simple. There either was one or there wasn't one. And then we go say, okay, do whatever you need to do, and the patient would get anticoagulated. Now there's a treatment algorithm depending on a variety of clinical factors, whether the patient has pulmonary embolism, if they've never had hypotension, and they don't really have any RV dysfunction or myocardial necrosis, it becomes a lesser category. If they have, the massive pulmonary embolism, we used to talk about massive just by how much clot there is. Massive is a clinical diagnosis, and it's clinical diagnosis with sustained hypotension, cardiac dysfunction, bradycardia, things like that. And those patients now, we're routinely going in and trying to get rid of that blood clot. So there's a variety of ways to do this. And you can do a few things. First, systemic anticoagulation. That used to be the backbone of therapy for this. Patient would get put on a IV heparin or some type of a drug like that. And the body would hopefully slowly dissolve the clot enough that they would get better. Systemic thrombolysis. People could get urokinase or streptokinase or tissue plasminogen activator, TPA, and that would, you give it as a systemic dose, and that will it'll try to dissolve blood clot anywhere in the body, and hopefully it'll work enough in the lung to let the patient get better. Unfortunately, it also dissolves clot everywhere in the body, so people get prone to bleeding elsewhere. Catheter-directed thrombolysis, where you put catheters up into the clot and then give it the thrombolytic agent, and it can be done in a variety of different methods. That will be that can be attempted. But the other thing is, and that's if you've got time. All those take time. What's the 2 up there? Is it telling me to go away? What time is my talk supposed to end? 10 o'clock, that's what I thought. I thought I was getting a hint from the back of the room. But anyway, submassive, is something that you've got time. Massive, you may not have time. These patients may be going into cardiovascular collapse, and you have to do something quickly. 25 to 75% mortality can be expected from people in this category. So one of the things that you can do is the catheter-directed thrombolysis plus or minus mechanical disruption of the clot. And again, we're back to anticoagulants, systemic thrombolytics, surgical embolectomy, or interventional therapy. A lot of our patients, if they're considered stable enough, sometimes the cardiac surgeons, if they have time and everything's ready, they can go in, open the artery, just pull the clot out, close it back up. Most of the time that doesn't occur because the patients, a lot of the clot's very peripheral and they can't get to it. If it's a central saddle embolus, they can do it. And also it's very risky at the time of induction of anesthesia. A lot of patients will die during induction and that doesn't work out well. So interventional therapies such as fragmentation of the clot. So this is a very, this was an older paper from Dr. Uflacker down at University of South Carolina. And what you do is you say, if this is the pulmonary vasculature, and here is the clot. So you've got this one volume of clot. If you break it up and let it go further out in the lung, the same volume of clot broken up does allow some perfusion. So you do get some more perfusion of the lung. So the patients can actually get much better if you just break the clot up and let it go peripherally. So that's one of the things that we used to try to do in the beginning. And we also did a combination of these techniques. You break up the clot and then give lytic agents. So with a catheter, put it through the embolus and give lytic agents. And here is a case of pulmonary emboli, and then after it has been broken, the clot's been fragmented, even with that, and with some lysis, it looks much better. It still looks terrible. Usually they look terrible, but the patient is better. The pulmonary artery pressures are much lower, the oxygenation is better, and they do very well. What we do now is we do have a variety of tools to try to suck clot out. And one of the, honestly, unfortunately, from an interventional standpoint, these cases can be very, very fun to do and very satisfying because you can have a pulmonary embolus and this is what you get out, all this thrombus. And it starts with a patient with severe massive amounts of clot. You can see this clot draping over going from upper lobe to lower lobe. And you can even imagine, where do these clots come from, usually? Deep vein thrombosis, specifically which vein? This is usually a femoral vein. So there's usually a piece of clot about this long, and it goes up into the lung, and it's a big worm, big snake of clot that's going back and forth in here, and it may break up. And this is one of the devices that is out now. This is an RA device that is called the FlowTriever, and it's a big catheter that you put a big syringe on, and you can suck on it, and you can also use this device here which has it's nitinol. It's like those Amplatz plugs, and you push this out past the clot, let it open, and you pull the clot back up towards the catheter. And you can get tremendous amounts of clot, Of course, for the picture, I took the time to lay this all out to try to make it look like a worm of clot. And you can imagine, this is the whole leg worth of clot. And afterwards, patient does really well and looks really good. So we're going to stop there.